At Nashville Knee and Shoulder, we treat a variety of issues related to sports medicine with a specific focus on injuries of the shoulder, knee, ankle, and wrist. Today we'll be doing an in-depth overview of a real-life case we treated here at the practice. Before diving into the details of a rotator cuff repair case, let's cover a few common issues that patients dealing with such an injury might experience. The number one issue that we see in patients in need of a rotator cuff repair is pain and weakness in the affected shoulder. Patients will also likely feel like they can't perform their normal day-to-day activities. Lastly, the inability to lift light objects without pain is a strong indicator that something may require more medical attention. In this particular MRI, we start by examining the coronal view. What that means is this is the view that we would see if we were looking directly at a patient. The first thing that we notice is the tissue that attaches normally to the outside of the shoulder, which is called the rotator cuff, is torn and retracted medially. Medially means more towards the center of the body. In this particular case, you can see a gap between the normal attachment and where the tendon begins, or in this case, ends. We also notice as we go closer to the medial aspect of the body that some of the muscle has atrophied. Atrophy in this case means that the muscle has lost strength and volume. Lastly, we look at the orientation of the humeral head. The humeral head is the bone underneath the rotator cuff. Now that the rotator cuff has lost some of its function, the humeral head begins to raise up out of the joint. These are all signs of an advanced rotator cuff injury. The primary issues with the rotator cuff are the loss of the attachment of the rotator cuff itself to the shoulder. This correlates directly with weakness and also with pain. The pain sometimes outshadows the weakness. A lot of patients complain about pain, especially at night. This is one of the most common problems I deal with at Nashville Knee and Shoulder. In this particular video, we've already positioned the patient. What that means is we're putting the patient in the ideal setting in order to allow access to the joint in order to fix his problem. I tend to do these cases in what's called a beach chair position. This is a funny name, but the patient is sitting up, slightly reclined, like he's at the beach, sitting in a lounge chair. What this does is allow us access to the back of the shoulder, and there's a small portion of the table that'll slide over and allow us to position our equipment through the back of the shoulder. The first thing that I'll do is establish a posterior portal. What that means is I'll create an incision in the back of the shoulder in order to place a camera inside the shoulder itself. Once I'm in the shoulder, I'll then establish an anterior portal. What that is my working portal. A portal in this case refers to a small incision, which is roughly the size at the end of your finger. This allows me to insert instrumentation and sometimes devices in order to fix tendinous tears or bone damage. And this allows access to all sorts of equipment that we can use in arthroscopic surgery to repair your issue. In this particular case, we've inserted the camera through the posterior portal. On the right side is the humeral head. This is the ball of the shoulder. It's covered with what seems to be fairly healthy cartilage. Cartilage in this case is the tissue that sits at the end of the bones. This allows for our bones and joints to glide smoothly throughout the joints in our body. On the inside of the shoulder is the glenoid. This is the small cup portion of the shoulder. Surrounding this is the labrum. The labrum's a cartilaginous structure that provides stability to our shoulder. Typically, as we age, this structure tends to get beat up and tends to tear slightly. This is normal and often doesn't cause symptoms. Typically, when I do a rotator cuff repair, I do see some damage to the labrum, as we see here. With the use of a shaver, which is the metal device that I'm inserted in the front, I'm able to remove the damaged portion of the labrum to remove any portions that may be causing the patient pain and also to stop any propagation of the tearing. The biceps is the small structure at the top of the shoulder. This is the long head of the biceps, and it's one of two tendinous attachments to the biceps itself. This is entering the shoulder and attaching to the superior labrum itself. We will cut this for later tenodesis later on in the case. What this means is that we're removing this damaged portion of the biceps and we'll reestablish an attachment of this further down the arm. This removes the sharp 90-degree angle that we see with the biceps tendon that often leads to pain and also problems with function. Now we're looking at the rotator cuff attachment itself. This patient has a large rotator cuff tear. There are some residual fibers present, as you can see. We'll take these fibers down to complete the rotator cuff tear in full, because this allows for us to more fully take the healthy tissue and pull this over to the patient's normal rotator cuff attachment, which is referred to as the footprint. Once we've removed the damaged portion and the unhealthy portion of the rotator cuff, we debride the bone itself. This means that we abrade the bone to create bleeding tissue. This will allow for better healing and ingrowth of the new rotator cuff. The next portion of this case is we're drilling forward and inserting 2 anchors. What anchors are small screw type structures, although I now use anchors that are fully composed of suture material. What this means is that they're soft type of structures, and if for some reason that they did come loose due to poor bone quality, it doesn't do significant damage to the joint itself. 2 anchors have been placed at this point, and after placing these 2 anchors, we're able to pull the rotator cuff back over to its native attachment, and this will allow for healing of the rotator cuff itself. At this portion of the case, we've inserted the camera over top of the rotator cuff. What you see above us is the undersurface of the acromion. The acromion is the bone that you can feel on the top of your shoulder, and this is a portion of the larger bone called the scapula. One issue that patients have is chronic impingement, and what this means is that the rotator cuff tissue itself, which is the soft tendinous structure in the rotator cuff, rubs against the undersurface of the acromion and can lead to tearing and oftentimes pain. What we'll do here is remove the undersurface of the acromion to allow the patient to have more space for motion of his shoulder. We've already placed the anchors and we've already prepared the rotator cuff for repair, and at this portion in the case, we're beginning to pass the sutures from underneath the tendon to over top of the tendon. We'll pass all 8 limbs of suture through the rotator cuff. There's 4 limbs of suture attached to each anchor. After we've passed all 4 limbs of suture through each anchor through, we begin to tie these down. These are done with what we call sliding knots. A sliding knot resembles a knot that can move up and down the primary limb of suture. So when I tie 2 limbs of suture together and I pull the non-primary limb, I'm able to reduce the rotator cuff into position and hold tension across the knot so these knots don't loosen up while I continue to tie them. We will tie all 8 strands together, which forms 4 knots in total. After tying all these knots, what you see is that we've pulled the rotator cuff back into position. It's now covering the footprint, and it now is in the position and has the ability to go on to heal. Lastly, we're pulling 1 limb of each tied suture over and placing these into 2 what we call lateral row anchors. What this is a backup as well as a second form of compression that we can place across the rotator cuff. We're tensioning these sutures, which allows for the lateral aspect of the rotator cuff to be pushed down against the exposed bone. This also provides a backup if any of these sutures were to become loose or untied. We place 2 lateral row anchors in a crisscross type of fashion, which provides for maximum pressure on the outside of the rotator cuff. At this time, we've finished the rotator cuff repair. All the limbs are demonstrated in this shot. What you see is a well-reduced rotator cuff with good compression against the footprint, and this will go on to a healed and very viable and pain-free rotator cuff with full function. Now let me introduce you to Rob from our care team. He'll review how the days and the weeks after an operation will be handled for a rotator cuff repair.
Welcome to your comprehensive guide on post-operative care and rehabilitation following a rotator cuff repair. After your rotator cuff repair, your sling will be your best friend. Wear it at all times, even while you sleep, with 2 exceptions: when you shower or when doing specific exercises, you may take the sling off. Remember, you'll be in the sling for about 1 month, so don't remove it unless instructed by the care team. Early removal of use of the sling can damage the repair. If you notice a rash developing underneath your arm from the sling, you can try by placing a washcloth under your arm or applying baby powder to keep the area dry. Gentle movement is key to preventing scar tissue and keeping your shoulder mobile as it heals. One great exercise is the pendulum exercise. Bending slightly at the waist, you let your arm hang down and make small circles, about the size of a basketball. Aim to do this about 2 to 3 times a day, but if pain is a limiting option, you do not have to do these exercises. Your physical therapy journey will typically start between 2 to 4 weeks after surgery. Dr. Jones and the team will discuss the right timing for you at your first post-op visit. You'll need to attend physical therapy about 2 to 3 times a week for 2 to 4 months to ensure a safe and steady recovery. Don't forget to schedule your therapy appointment as soon as you have your prescription in hand, and reach out to our office if you run into any issues with scheduling therapy. It's normal to see some bleeding through your bandages after surgery. If that happens, you can reinforce it with gauze. After 48 hours, you can remove the bandage, but leave the surgical tapes or steri strips in place. We will take the sutures off at your first post-op appointment. Once the bandage is off, you can shower, but keep the incision area dry until your stitches are removed. Hold your arm against your body while you're showering as if it is still in the sling, and avoid submerging the shoulder underwater. You can take 1 pill every 4 hours while awake, or if needed, 2 pills every 4 hours. Remember, don't set an alarm to wake up just to take the pain medication. Instead, take it as needed. Don't wait until the pain becomes too severe either. You can also use Tylenol, Aleve, or ibuprofen for additional pain relief, but avoid taking them at the same time as your prescribed pain medication. To prevent constipation associated with opioid pain medication, consider using over-the-counter stool softener or something like Miralax. If you're having severe difficulty with your pain management, you can always give us a call and we can adjust your dosages as needed. So a few tips for sleeping after a rotator cuff repair. It will be tough for the first few weeks. You'll need to sleep with your sling on, and many patients find that sleeping in a recliner is much more comfortable than sleeping in a bed at this time. Remember, it does get better with time. So weeks 0 to 2, you're just going to be at home working on some gentle range of motion so you don't build up too much scar tissue. Weeks 2 to 4, you're going to start your formal physical therapy where the goal is just to obtain your full range of motion back. Weeks 4 through 8, your physical therapist will start to incorporate more strengthening along with continuing to obtain your range of motion. Remember, every patient's recovery is unique, so follow your specific instructions and stay in close contact with your care team. Thanks for tuning in. If you have any questions, please reach out to me, Josh, or Ansley, and we'll look forward to seeing you at your first follow-up appointment.
If you or any loved one are dealing with an ailing joint, reduced mobility, or chronic pain that just won't go away, reach out to our team and schedule an in-person consultation. We'd be honored to play a small part in getting you back on the field of play, whatever that field might look like.